And let's move on and have Casey, Megan, Jack, and Tim Lee from Milwaukee, Atlanta, Omaha, Toronto, and Houston join us. And at the end, we're going to have Grace talk about Dr. Swenson and Martin. Okay. So, switch gears. Let's talk about another favorite subject called Hirschsprung's disease. And we have this patient. It's a new Hirschsprung's diagnosis. We've confirmed that by rectal biopsy. The patient is clinically well. Irrigations have gone well. And we have to decide on our surgery. Would we do a transanal only operation, a transanal plus laparoscopy, or a transanal plus umbilical approach? Let's go to the questions before we have an answer from the panel. So let's hear your votes. And maybe we'll start with our program chair, Dr. Calkins, playing a double role here. Now, let me ask you, if something goes wrong with the program right now, what would you do? Do you have a backup call? Or?
Yeah, I think I'd be fine. The APSA staff has done a tremendous job doing everything, and they do all the hard work. We just put all this stuff together, so I'd be very comfortable. I would agree. Personally, my practice is to do B, mainly because that's how I was trained, and I find it to be the most easy. But I empathize with those that would choose A and C because I think they're both reasonable options if you are comfortable doing those two operations in this particular setting with this contrast study. So I like B because I find it to be easier, but I think the C option specifically is attractive, and I think that's what Dr. Langer would probably say to this one if I'm...
Jack, is there ever a role for transanal only?
I think it's a bad idea to go transanal only because there are going to be some cases where the contrast study is inaccurate and the transition zone is much further proximal, even sometimes total colonic. So unless you're prepared to do a primary pull-through, transanal pull-through for total colonic disease in a newborn, I think you better find out where your transition zone is before you start the transanal dissection. And I think whether you use laparoscopy or an umbilical approach doesn't matter. I like the umbilical approach because I like to teach it because there are many, many surgeons in the world that don't have access to laparoscopy for small babies, and so I like them to be able to use some way of doing the biopsy in advance without laparoscopy.
I think over time this has become a less and less controversial question, right? Because there have been many misadventures of not knowing where the ganglion cells are before you start doing something definitive. The only footnote I would add to that, I think there's some patients like the older Hirschsprung's child, the 3 or 4-year-old, they're quite rare, almost always have a very low transition zone. The rectum looks more bulbous. Potentially that could be a transanal only. But I agree with Jack and has convinced me to make sure we have the correct diagnosis laparoscopically before we start. Plus, the laparoscopy is very helpful for the dissection, or the umbilical approach is very helpful for the dissection. And I also think will minimize the amount of stretch required to do the transanal part, which is a significant component of the morbidity, which I hope we have some time to get to. All right, let's go to the next one.
Mark, can I ask you and Jack a question? I always hear from the transanal people that you say, I can get the whole colon out through the anus. So if you can get the whole colon out through the anus, why do you care? Is that true or not? I mean, there's got to be a limit. I don't do transanal because I worry about getting something above the sigmoid colon. I find that to be very difficult, and what you just said is, I think, really important. So I think it's really important that you don't do just a transanal, because I don't think that's true. I don't think you can get the whole colon out.
Casey, I'd agree with you, and as someone who has done a number of transanal onlys, I can reach about the mid-sigmoid comfortably, and then it starts to get a little bit uncomfortable. But honestly, at this point, I really want to know the location of the transition zone before starting, so it's really not relevant. And if it's a older child, then I'm very confident I can get to it, and those are the only ones I'm still doing transanal only on. Does that answer your question?
Yes, thank you.
Okay, so let's say we are in the middle of our definitive pull-through, and let's say we've gone for laparoscopy or transumbilical, either way. We're in the abdomen, we haven't done anything transanal, and it's time to do our biopsy. So how would you do the biopsy? Would you do a seromuscular only biopsy, a full thickness biopsy, laparoscopic, or transumbilical full thickness? So let's go to the questions. So we have the laparoscope in, as you see in the picture. And what is your practice for leveling this patient? You think that part of the sigmoid is looking good?
Is there an option to do A, but you do B?
Is there an option for what?
You try to do a seromuscular, but you do a B. You do a full thickness.
Well, that's
my practice.
I think I think that's right. That's Dr. Pena taught me that the operative note is what the surgeon intended to do, not what the surgeon actually did. Yes, and I think that's a very important point. I think most folks are trying to do a seromuscular only biopsy, as noted in this in the poll, and that's the point I want to try to get to. So, Tim, do you have any problem with a seromuscular only biopsy?
Personally in my...
Microphone.
Can you hear me?
Yeah, it's on.
Okay. So I think I do a little bit of a variation on that. I think you can do a seromuscular biopsy, but often when I put the camera in, I can kind of you try to get a sense for where the good colon is a bad colon, and I usually have a 5 millimeter port through the belly button, and I will just actually reach in there with a grasper, pull out the area that I want to biopsy. I will take a full thickness biopsy just to make sure that I'm sending enough to the pathologist, right? They never have enough tissue, is their usual complaint, and then I can just quickly close it, dunk it back in, and then, put my 5 millimeter port back in. So I kind of do a little bit of a hybrid. It just seems to be a little faster.
Yeah, and if I can just add to that before I go to the next question, I think we don't want to be waylaid by pathology. I've seen many, many pull-throughs that have been beautifully done by the original surgeon, but the pathology was off. And they need to be redone because they were done to the wrong part of the colon. So my strategy is similar to Tim's, is I bring the piece of the bowel that I want to biopsy out the umbilicus and do a full thickness biopsy. And by the way, I do a square. People sometimes do this sort of triangle cut. And then what ends up happening is the mucosa is this tiny little patch, and it's like an iceberg. Whereas if you give them a square, and I actually cut a square, then they have no problem orienting the specimen. They know what side is mucosa and what side is seromuscular, and you get a very accurate biopsy. Whereas if you cut a triangle, which is basically what you're doing with the laparoscope, with laparoscopic instruments, you get, and by the way, in that case, you're only getting seromuscular, which we're going to talk about in a second. But if you get a little bit of mucosa, it's going to be tiny. And then you have to sew it up, but then the pathologist may disorient that, and they don't get the right slice, and they give you the wrong information. So that's one factor. Now, the other factor that's very important is if you do seromuscular only, because you don't want to sew it up, you may very well see ganglion cells. However, the submucosal layer could very easily have hypertrophic nerves. So essentially, you have been convinced that you are in a good spot, but in fact, you have to go a little bit higher. Now, if it's your practice to go a little bit higher anyway, or if you want to do the pull-through and then send another full-thickness specimen, by all means. The seromuscular biopsy was a very helpful guide. But unfortunately, there are a number of pull-throughs that are done where the only biopsy taken is the seromuscular one, and the patient ended up with a transition zone pull-through. And we'll have time, I think, at the end to talk about that. So let's go to the next slide. So first of all, this is one of my favorite Hirschsprung's pictures. This is the world record of projectile for enterocolitis. If anyone wants to challenge this picture, please send it to me. It's a tiny baby on the left, and I think we got about 6 or 7 feet. So you know what is brewing in that colon, of course, with bacterial overgrowth in that child. But let's talk about now the patient has had their pull-through already, and they develop enterocolitis. The pull-through was done at 1 week of age, and the child is now 1 year. Okay? And I've intentionally made this difficult on you. So the patient had a newborn pull-through. It's a year out, and the patient has enterocolitis. What would you do? Let's
Mark,
go to
their stooling pattern between those two times has been what? Normal?
They've been doing well.
Normal.
And then the sudden episode of enterocolitis. So let's see what the audience thinks, and then we'll go to one of the Megans. The Megan without the H. Okay, so let's see what everyone thought in 1 second. There we go. All right, look at that. Well, what do you think?
We were just discussing neither of us have an H in our name. But despite that,
Are you serious?
I think
Are you both Megan? Oh, I am so sorry.
we should have sat next to each other. But I think Casey's point is a good one. If this is a single bout of enterocolitis, that's a different child than one with multiple bouts of enterocolitis and an obstructive stooling pattern. I think when you're looking at a kid with an obstructive stooling pattern with multiple bouts of enterocolitis, you're thinking about all of the above. You're trying to find why is this child getting recurrent bouts of enterocolitis, and it's up to you to prove that there's not a transition zone pull-through, there's not something anatomic, and then you can try Botox, because we know all of these kids have non-relaxing sphincters, and sometimes I've seen good success in the kid that doesn't have something anatomic with a trial of Botox.
Jack?
Yeah, I think if this is an isolated episode of enterocolitis in a child who's previously done extremely well, I probably would just treat the enterocolitis and send them home and hope that maybe it was just a viral illness that precipitated it and he's going to be fine. But I think in a child who's had recurrent bouts of enterocolitis or one severe bout, then I follow the algorithm, and we've actually, the APSA Hirschsprung's disease interest group has published an algorithm to try and work through this. And it would involve ruling out a mechanical obstruction, and the contrast enema and a rectal exam will do that. And then you want to do a rectal biopsy to make sure it's not a transition zone pull-through or aganglionic. And while I have the child asleep to do that, I would do an injection of Botox, because most of the time the biopsy comes back normal. So you can avoid an extra anesthetic by just doing the Botox and seeing how they respond to it.
Just two clarifications. What is your threshold for doing all of this? A second episode, third episode? Does the age matter? Just repeat that.
So it's interesting that many of the children with enterocolitis don't develop it until later on. And there's also overlap between the child who has enterocolitis and the child who just has ongoing obstructive symptoms. And sometimes they don't really present that way until they transition from breast milk to solid food. Often they're over a year old. So I think you have to individualize. With enterocolitis, as I said, if one episode I think I'd allow a child to have. I think if they have 2 or 3 that come as a recurrent problem, then you go down that path.
And then your technique for Botox?
I always put them to sleep. I don't use ultrasound guidance because I don't think it's necessary, although some people do. I use a 27 gauge needle. I take 100 units and put it in 1 cc, and then I do 8 injections circumferentially at the dentate line, going in a couple of millimeters in each injection to try and get the sphincter.
Very good. All right, let's go to the next slide. Okay, there's no audience response needed here, but this is one of my favorite topics, is based on your choice of what kind of pull-through you do for Hirschsprung's, what residual Hirschsprungs are you leaving behind in each of these techniques? So the technique on the left is a suave. So Tim, what Hirschsprung's is being left behind?
So I think obviously all these techniques, the sphincter complex is going to have Hirschsprungs left behind, and that's where you have the non-relaxing sphincter, which is just part of the disease. I think in the one For the Suave, you're leaving a Hirschsprung's design within the cuff itself.
Okay. So, yes, I agree. And that's something that has to be remembered. No matter what operation you do, the sphincters, unless they got buggered up by the operation, still have a non-relaxing internal sphincter, which may or may not need to be dealt with, and the baby needs to learn how to overcome that. The Suave on the left has a cuff. The Swenson in the middle really doesn't have any residual Hirschsprungs except for the little zone that you've left behind to preserve the anal canal, which usually has no effect. And then the Duhamel obviously has the residual rectum, which is Hirschsprung's. And then, of course, Rabine is literally a low anterior resection, leaves behind the rectum itself, but most surgeons don't even remember that operation because it's not done anymore. So let's talk about some problematic Hirschsprung cases. These are actually 3 different pull-throughs. So I'm going to let you study those for a little bit, and you can plan your answer, but don't advance to the next slide, please, because the pictures get very small and you won't may be able to decipher them. So we have 3 different pull-throughs. Now these are patients that have had their pull-through and that are coming back with recurrent episodes of enterocolitis. So clearly something's wrong with them. And then it's your obligation to figure out what is wrong with them. Why are they having obstructive symptoms? And I basically have given the answers there. So formulate in your mind which letter you'd like. And then let's go to the next slide and get the group's answer. And the pictures are smaller, so not as easy to see. And Megan Durham. Can't believe I made that H mistake. You're at the art museum. You see these works of art. What do they say to you? So let's see what they thought. Transition zone, twist, and cuff. Nice job, right?
I agree.
Your microphone is working?
Is it on? I'm not sure if it's working.
Maybe move the little guy closer. No.
So I agree with the audience. The first picture to the left does appear as if there's a transition zone left because the rectum is still, or the distal bowel is still much more narrow than the proximal bowel. The far one to the right, it's a very good picture because on the lateral film, whenever there's a cuff left, it will take the rectum further away from the sacral bones because the cuff can roll down and actually provide an extra bit of barrier between the column of the bowel and
Very
the
good.
spine.
Yeah, so again, all of these can be discerned on a contrast study, and obviously the one on the left would be confirmed by a rectal biopsy. And in the one in the middle and the one on the right, you really need to do a digital exam because you can feel a twist often. You just can't quite get your finger into the pelvis. And I like to do a rectal exam and palpate the abdomen and see if I can feel the tip of my finger. And if I can't, I'm hitting the wall. That's typical of a twist. And often you can feel a cuff around the pull-through. And if you were to scope such a patient, you wouldn't say anything that was wrong. But if you put your finger in, you can feel that there's like a rubbery band on the outside. Okay, let's go to the next one. Let's talk about one of the non-answers, non-relaxing sphincters. Everyone see the picture on the bottom? It's one of my favorites. So let's say we have a patient who you've checked out that has no residual Hirschsprungs, no cuff, no stricture, no twist, and they're still misbehaving. What's your protocol? You alluded to this a little bit, but how do we deal with that patient, Casey?
I do exactly what Dr. Langer said to do, and that is I use Botox. I like to use ultrasound because I'm young and trying to gain experience with that modality, and it's a good place to use it. I think Marcus presented a video here at APSA a couple of years ago about how to do it. So it's intriguing, but I used to do it without it, and I don't know if it makes a huge amount of difference, although the Michigan folks would suggest that it does. Anyway, so I would do Botox. I use 2 cc's, but I think it doesn't really matter a whole heck of a lot. I try to avoid the anterior part of the rectum because I feel like if I get too deep, in a boy especially, I might get into the periurethral tissues and cause a problem with urination. So I try to avoid that, but otherwise I do exactly what Dr. Langer did.
Jack, anything to add from your previous comments?
Well, I guess only that Botox is a diagnostic technique and it's also a therapeutic technique. So if you've ruled out mechanical obstruction, ruled out a pathology problem, and you give Botox and it makes them a lot better, then you have made a diagnosis. You've determined that non-relaxation of the sphincter is a significant part of that child's problem. And then you can go ahead and give repeated Botox injections over time, and in most cases, they'll grow out of that problem and not need it anymore. If they don't have a response to the Botox, then, and they have no mechanical problems or pathology problems, then you have to move to the next step, which is to rule out some kind of motility problem in the bowel that has ganglion cells, in the pulled through bowel.
Dr. Langer, if you do it once and it doesn't work, do you try it again because you think it might be user error, or do you just assume that you're good, you got it in the right spot, and it's a problem with the Botox is not going to work, or do you try it again?
No, I'm not that self-confident. I try
So
it
you do
again.
it again.
Yeah, and it's not only that maybe I injected it wrong, but it may be that that particular lot of Botox might not have worked. And I know Mark has had some experience with different types of Botox,
Right.
botulinum toxin, because sometimes one type will work and another type will not work.
That experience is actually quite limited, and I think it was you who made the suggestion to me, or one of you guys, that I had a patient that I kept Botoxing that I was very convinced had nothing wrong with their pull-through except for their sphincter, and they kept not getting better. And I felt my technique was right, and someone said that there's different types of Botox, and you can get antibodies to one of the types, so if that happens, you should switch to a different type of Botox, which I tried, and it actually worked on 2 patients. So that's exceedingly rare, but it's something to keep in your back pocket.
Can I add
All
one
right.
thing also?
Yeah, please.
If you're getting to this point where you're needing to Botox a patient, you should, if you are not, already have not done it, you should teach parents how to do irrigations, because that's an important part of maintenance if you're running into problems.
I agree, and I just cannot emphasize how important it is. If you're going to go ahead and do the Botox, just make sure that the pull-through is okay, that there's no stricture, that there's no cuff, that there's no twist, because there is a very fixable way to make that kid completely better, and Botox may help in the short term, but symptoms will keep coming back. So just keep in mind that there are some anatomic fixes out there for pull-throughs that can make the child dramatically better. So those were the post-pull-through obstructive comments, which we may be able to have some time to get back to. Let's talk about the other side of the post-pull-through problem, and that is the soiling patient. Often it's a patient that's not obstructed, not distended, they just keep soiling. So let's talk about what to do with this patient. So post-pull-through soiling, the child is 4 years of age, and what are our next steps? Let's go to the next slide.
They had standard rectosigmoid disease.
Yeah, all of these, this is all standard rectosigmoid disease, had a pull-through, and the pull-through was done well. And let's see what everybody thinks. So Jack mentioned the algorithm for the obstructed patient that is an APSA initiative published. There is now a algorithm for the soiling patient that's in publication, and I can show that at the end. Okay, so Megan?
Me again?
You have a
Megan?
four-year-old in your clinic,
Yeah.
and they're soiling.
So I think you have to figure out the mechanism of their incontinence, if this is true incontinence or pseudo-incontinence. So you need to see if this is overflow incontinence from a kid who's been chronically obstructed, or if this is a sphincter problem, injury to the sphincters, lack of the dentate line, to help you make your decision. And so I think this is another situation where we're thinking about all of the above may be appropriate in that patient, depending on their background.
Except I don't think I would start with
I
Botox in a
wouldn't start with
soiling
Botox,
patient.
I agree.
Yeah.
In a soiling patient.
All of the
So-
above except Botox.
But if I got a contrast enema that they were chronically backed up, maybe.
Yeah, so the contrast study obviously looks for anatomic
said
problems.
zero.
The examiner anesthesia and rectal biopsy, we already discussed. We talked about Botox. What's the value of anorectal manometry, Jack, in this scenario?
Well, I think there's two things you can learn from anorectal manometry. The first is whether the sphincter muscles are adequate. You may find that they have had damage to their sphincter. Usually it's during the time of the pull-through, but if they have very low sphincter pressures, then that could be an explanation for the soiling. The other thing is that part of manometry is blowing up a balloon in the rectum and asking the child to tell them when they feel it. And if they have lack of sensation of a full rectum, that can also contribute to soiling. So I think manometry is very helpful.
Yeah, and just to emphasize very important words that Megan said, is you have to figure out, does this patient have potential for continence or not? And in an ARM patient, their potential for continence could be limited by things like an abnormal sacrum and an abnormal spine, even though you've done a beautiful operation. In Hirschsprung's disease, all those patients should be continent. And if those patients are not continent, there may be a problem with the sphincters, i.e. they were overstretched, or the anal canal, which might have been resected if the dissection was started too low, or both. And those patients, unfortunately, will be incontinent and need a bowel management mechanical program. But if the anal canal and the sphincters are good, and we use anorectal manometry to confirm that, but you can pretty much look on physical exam, and if the anus is closed, their sphincters are good, and if it's wide open, the sphincters are potentially injured. But if the anal canal and the sphincters are good, then we have medical management ahead of us, which we're going to get into. Okay, so let's delve into this now. So what has happened here? These are two different patients that are soiling. Take a look at these pictures. And now let's go to the question. So, Tim, what do you see?
So on the picture on the left, that anus looks like it's patulous. So that possibly could be like an injured sphincter or something that was overstretched during the initial operation. The one with the Lone Star in, I don't really see a dentate line in that as well. So these are probably kids that would then fall into that possible category of true incontinence, and then would probably head down to another pathway than the child for the pseudo-incontinence. But I think back to the pseudo-incontinence, just one quick thing about like the obstructive symptoms. I think sometimes after you get these kids to fully empty, we've been putting them into like psychology as well as physical therapy, because it almost seems like they have to almost relearn the way to kind of sense when they need to stool, because they've been obstructed and soiling for so long, and we found that to also be helpful. So if you have those resources available at your institutions, those are also can be an adjunct to what you would normally do, like from a medical management or surgical standpoint.
So, yeah, so those are both unfortunate post-operative problems that were potentially preventable. All right, so now let's talk a little bit about these two patients. So this patient has been found to have intact sphincters, an intact dentate line, and is soiling. What would be your treatment? Let's go to the questions. Now, again, no obstruction, no distension, no enterocolitis, normal sphincters, normal dentate line, and the patient is soiling. What would be your treatment plan? Megan, you want to take this one?
Obviously, if they're still stooling and everything's still intact, they are not able to control what's coming through. And with their colon moving that fast, manometry could be helpful, but for medical treatment.
Why do you say the colon is moving that fast?
If they are an intact child of toilet training age and they cannot make it to the bathroom and they're not obstructed with stool, and it's not overflowing,
Right.
then they're not actually able to make the sensation, the connection that they have to go to the bathroom and get there on time. So things are probably just moving a little too fast for them to actually manage.
Yeah, so I just want to make sure everyone made that same leap that Megan made, because that's what you should see in that image. Again, I made specific emphasis to the fact that this is not obstructed. A lot of people say, well, it looks like the left colon is narrow and maybe that's retained aganglionosis, and well, that's not going to be the case in a patient that's stooling with no obstruction, right? So that might look like a residual Hirschsprung's contrast study, but not in a patient who's clinically stooling with no distension and no obstruction. So this is a patient that I agree is moving too fast. So this is a patient that came to me with soiling that was on Senna. Guess what I did? Brilliant. Stopped the Senna. In 2 days, the child was perfectly continent. So the surgeon assumed that the patient has Hirschsprung's and therefore must have constipation. And that's not true. In fact, I'm amazed, actually, that more patients with Hirschsprung's in whom a rectosigmoid has been removed, why aren't more of them hypermodal? It's amazing, right? If we take out a rectosigmoid in any ARM patient, it's big trouble, right? We know that from the abdominal perineal pull-throughs of the past. Those patients have no reservoir. But a Hirschsprung's patient, they can maintain their continence. A J-pouch in a ulcerative colitis patient maintain their continence despite super-duper motility. Why? Because their anal canal and their sphincters are intact. So this patient is just hypermodal and needs to be slowed down, and if the move is to stop the laxatives, great, but the move could be give some Imodium and slow them down that way, or some water-soluble fiber. Try to get them to one formed stool per day, and all of a sudden you'll have a continent patient, provided the anal canal and the sphincters are okay. All right, and let's do this one. So this is, again, same scenario. Intact sphincters, intact dentate line. They are soiling. No enterocolitis, no distension. But something's different, obviously. And let's go to the question slide. And what would you do for this patient? And I'll have Jack, you take this one.
Now, I would use stimulant laxatives because this is a child who's got a full rectum and is usually it's either overflow or, more commonly in my experience, it's just the little bits of stool kind of coming out when the child is not paying attention. And if you can empty that rectum, keep it empty, then they'll do much better. And I would start with stimulant laxatives, although some of these kids may end up needing enemas.
So, Tim, why did so many people give enemas? And how would you distinguish between laxatives and enemas in this patient?
You know, I think based on whether they have the ability to actually be like fecally continent. So if it is a pseudo obstruction and you can kind of get them clean, then they should have the ability to be continent. So you can put them on laxatives, and those laxatives should work, and they can, you know, have the correct kind of stooling pattern. I think for us, or when I think about it, enemas may be reserved for the kids that either can't tolerate the laxatives, either due to the side effect profile, or they can't, you know, once again, they have true fecal incontinence. And then we would go to enemas with probably the further plan of having some type of procedure to allow them to give it antegrade, because, you know, what kid wants to get rectal enemas from their mom for the rest of their life, right?
Yeah,
So.
no, I mean, I think that's a good point. Again, to repeat Megan's point from earlier, are the sphincters intact? Is the dentate line intact? And then, of course, what's the behavioral situation of the patient? What's the age of the patient? Did you want to add something to that?
I was going to add the length of the symptoms could be a factor in this. If this is a kid who's had obstruction for 5 or 6 years, it may be reasonable to start on an enema program and then plan to transition back over to laxatives after things have had a time to shrink, because there's some chronicity to that, and you can struggle.
It also, I think, if you, by using the enema program just to start with, you start giving them the sensation of full rectum, empty rectum, full rectum, which does part of the training that they need to relearn for stooling patterns.
Yeah, I think those are very valuable points. an enema program is not like a defeat, right? In fact, an enema program could get them very, very well and happy. And I like to say that I think it sets them up to future success with bowel control because they've learned what it's like to be clean, even though you've done it artificially.
I know this is unusual, Mark, but I'd like to disagree with you on that.
Bring it. Happy to.
So the problem with enemas is a lot of these kids, especially if they're 3 to 5, they're anally defensive. They are stool holders. And stool holding is a common thing in normal children, but I think it's even more common in Hirschsprung's kids because they have that tendency towards hard stools and chronic constipation. So if you start attacking them from below, it actually makes that stool holding worse. And so that's why I prefer to start with the stimulant laxatives. And if that doesn't work, sure, then you sometimes have to go to enemas. But
I think this is a discussion you have with these families. You figure out, is this one of those anally defensive kids that this is a no-go? Then you say, I'm going to try stimulant laxatives, and if we don't get there, then maybe we're going to have to go to an antigrade because we know that's a no-go, but we'll give it a try.
Yeah.
And if we don't get where we want to be, then maybe we make a different decision.
And again, there are patients with Hirschsprung's that have behavioral issues, Downs, autism, etc., that do not have the mental capacity to have successful voluntary bowel movements at the age of 4. What do you do with that child? Rectal enemas are great. If they won't tolerate them, then we have other options like an antigrade enema. Don't forget, though, if you have a behavioral Hirschsprung's patient with perfectly normal sphincters and you do an antigrade enema on them, you got to Botox the sphincters because their sphincters are so good that they will defeat your flush. They will hold in your antigrade flush. So we have some time to open up to the audience on anything we've discussed. And I see the shiny head of Steve Rothenberg coming to the microphone, and I have one myself, so I'm allowed to criticize or compliment.
Oh, well, thank you. It's quite nice to be recognized because of my shiny head. So I have a question for the panel, and it has to do with the concept of, it was mentioned basically most on the panel would favor using laparoscopy or transumbilical approach to identify the transition zone so that you're not fooled and don't start the endorectal part before you know exactly where the transition zone is. And I totally agree with that. Although I guess I'd like some clarification because I think that actually there's more reasons not to just do a transanal total endorectal pull-through. And as you all know, the Nordic multi-center study came out 2 years ago and showed that when they compared those who did a total transanal endorectal pull-through versus using a laparoscopic assisted approach, that the outcomes were statistically significantly worse in the transanal component. And the beauty of their system is they are able to follow every patient over the course of their life. So this was every patient who was 4 years or older where they could either query the patient or query the parents. And I think, yeah, you may be able to dissect out the whole colon transanally, but most of us who are not as skilled as some on the panel, trying to do that operation totally transanally are going to end up injuring the sphincters, and I think their study shows this. And so I just wondered, does the panel agree with that, disagree with it? Is it really the only reason you're doing it laparoscopically is to determine the level site, or is there benefit to not trying to dissect out, to limiting the transanal portion to really just the area of the external sphincter where you can do the release internally laparoscopically all the way down to the pelvic floor?
Yeah, 100%. I think we sort of mentioned that. I think the laparoscopy is great for a number of things. It's biopsy. You can take the arcade, the sigmoid arcade. You can take the left retroperitoneal attachments. You can take down the splenic flexure. And your deep dissection into the pelvis is beautiful, better visualization, I think, and then you have very little transanal work to do. I think a lot of the overstretched sphincters that we see that have incontinence are as a result of a more aggressive transanal approach that would have been necessary than if the surgeon had done more work laparoscopically, they would have had less to stretch transanally. So I completely agree with that assessment. Yeah, and plus, what are you going to do while you're waiting for the pathologist? You might as well do some laparoscopy work, right?
Exactly.
Because in our place, you got about 40 minutes, and they're very good. And we don't have enough jokes to get through the 40 minutes, so we need to do laparoscopy to get down into the deep pelvis.
Can I add that I do think that, I mean, you're obviously a very skilled laparoscopist, but I think some people get themselves into trouble by trying to get too low laparoscopically because they're scared of the transanal portion, and then they cause harm. And so I think that there's a balance there, and you can get very low very safely, but depending on your laparoscopic skills, you can also run into trouble in the opposite.
Steve, can you come back to the microphone and just give us some tips on the deep pelvic dissection? Because I think the original Swenson got a bad rap because the transabdominal dissection into the deep pelvis was in the wrong plane and caused a lot of trouble, which led to the development of the Suave and the Duhamel. But a well-done Swenson plane doesn't have that trouble. So how do you do a good perirectal dissection without causing injury?
Well, I think the key really is to stay right on the bowel wall. I mean, we have the techniques and the ability now, and laparoscopically, and we do primary pull-throughs, so they're not protected, and often will be anywhere from a newborn to 1 month of age, depending on the size of the patient and the parent's ability to irrigate and surgeon preference. But I think the key is really staying just on the bowel wall, and I think now we have the equipment that allows us to do that very safely, variations on bipolar technology and things that allow us just to dissect and tease all the way down on the bowel wall. In males, you obviously need to be careful about the prostate and the vas deferens, but if you stay on the bowel wall, it's just a safe plane. Now, if you go down there, and as I used to, I think, people have, using larger instruments, using monopolar cautery, all those things can create energy, but we don't need to do that anymore. And I actually think for people who are doing laparoscopy, this is not something where they're big vascular structures. The visualization is incredible, and I think most of us, what worries me the most is when I watch somebody do the anal portion of this dissection, is that they're putting retractors up in the external sphincter.
Yep.
I never put a retractor in the if you're putting a retractor inside your anal dissection, then you're doing something wrong, because the dissection should always be outside of the dentate line, really. I mean, it should be coming out at you. And so, but I watch many surgeons, as you guys all know better than I do. You do this a lot more than I do. But you watch people, and it's the first move is to put a retractor up there and to try to get into that plane that they're doing in. So I think basic laparoscopic skills actually allow you to do a much safer procedure and limit the transanal portion of the operation. And if you're having to put a retractor in the anus, then I think you've done something wrong. So that's how I do it. Just stay on the bowel wall, gently work your way down, and I think it's very safe.
Thank you for that.
Can I just add to that, Mark? I agree 100% that you should never put retractors in from below, but I don't think that you necessarily need to use laparoscopy to get way down low. For example, I don't use laparoscopy, I use the umbilical approach, and I do the dissection down to the peritoneal reflection. And then I can get up to there very safely by pulling down on the rectum and doing the entire dissection on the outside from below. As long as you're doing that, I think it's safe to go from either direction.
I think that's the key. But again, you're very skilled, and I think it's an easier concept for you and ability to do that than many who they're stuck. And so what they do is they start dissecting up in the canal. And so again, many surgeons can do this transanally without that injury, but I think the studies show that for the vast majority, there is a worse outcome.
Yes.
Luis Martinez at Tampa, Florida. My question is regarding your first patient in the presentation. Is the option of doing a colostomy and deferred pull-through still acceptable in our pediatric surgical community today? Can that still be offered to parents of an infant with Hirschsprung's disease?
I think it depends, but the answer is yes. It really kind of depends on the circumstances. You had mentioned traveling, doing overseas work. That's one situation where I always do a colostomy, mainly because there's no pathologist. Two, if there are other comorbid conditions, that's certainly a patient that you might want to divert for a while the other stuff is getting sorted out. And then the older patient who has a late diagnosis of Hirschsprung disease, those to me, I prefer to divert, allow the colon to decompress, make a diagnosis, and then do my definitive pull-through later, although I know that's controversial. But to do it in the neonatal period is probably just a matter of personal preference. I am very comfortable doing primary pull-throughs because I think the evidence is there, but is it acceptable or not? I think it's probably acceptable.
I think it's acceptable, but not optimal for the child.
But obviously, those situations are very real, and there are many parts of the world that deal with Hirschsprung's disease just that way, and they actually don't have pathologists.
Right.
They just open the bowel in the dilated portion, the patient thrives, does well, and then they pull through the part that's been working in vivo. I apologize, we need to give Grace Mack some time to do our tributes. So thank you very much to the Hirschsprung's panel.